Yeah. So shall I give an introduction for 2 minutes and then?
Fine.
Good evening, everyone. I'm Dr. Tanveer. I'd like to take a couple of minutes to just introduce uh, to the today's session, everyone to today's session before we start off with the session proper. I feel a sense of pride to welcome you all to our IAN guest lecture series. Now, the success of IAN has been a credit to all the colleges who've been part of IAN from the time of its inception. Most importantly, to all the consultants who have been such good teachers, guides, and sources of inspiration to all of us. From the inception of IAN, they have been very gracious to take time, extra efforts, and time off their personal space just to moderate these sessions, guide us, and enrich us in our knowledge. We shall forever remain indebted to all our consultants for this. I'd also like to thank all the academic coordinators and importantly the students themselves who have been actively participating and have been helping us to keep the group up and going. For many of you who don't know, I'm Dr. Tanveer Nawab. I have been coordinating, rather trying to coordinate your academic sessions at IAN. Some of us started off as students presenting at IAN, and then we have been coordinators, and now we are working as faculties at different colleges. One such dynamic faculty is a dynamic
It's a
colleague
dynamic colleague.
is Dr. Gunjana, who is working as an assistant professor in Department of Neonatology at NIMS Jaipur. She's been instrumental in materializing our idea of this guest lecture series. She'll be moderating today's session, which will be held by Dr. Sunita Bijarnia ma'am, who is one of the pioneers in the field of genetics. There are very few people in the field of medicine who probably do know of ma'am. We were overwhelmed by the response we got, in fact, when we announced that ma'am will be a speaker today. I humbly invite ma'am and I request Dr. Gunjana to take over from here. It's over to you, Dr. Gunjana.
So thank you, Dr. Tanveer. Without wasting any time, I think Dr. Sunita ma'am doesn't need any introduction. She has been always very, very supportive to us, even in discussing the cases as well as whenever we need her for the academic session. So ma'am, I'm just making you the host and you can share your screen.
Yeah. Okay. Thank you, Dr. So let me just start off. So are my slides visible?
Yes, ma'am, they are visible.
Great. So I thought we'll just have an informal discussion. Please interrupt me whenever you want, because we all want to learn, right? And I may be making some mistakes. So let's just start now. So basically, we are now wanting to learn about genetics. And what best place to start than a neonate, the start of life. But you know that majority of genetic disorders do appear at the start of. So many appear that is in the gestational period. All the major malformations, like the chromosomal disorders, where the defect is so huge that a baby is not able to survive. So the earlier the bigger the defect, the earlier is the presentation. So that's why neonatology is the branch which really faces the wrath. All genetic disorders can manifest here. So it's really important for us to understand what this genetic basis of these disorders is. So it's not very difficult, because I know you all know about this. Like it shows.
X-ray what clearance यार tube is so in यहाँ पे ऐसा है.
I request everyone to
please. देखा है but बहुत इसने निकाला है क्या?
Dr. Shweta,
so here is
please me.
तो ये कितने पे था? ये भी इस पे ही होगा ना?
maybe the host can mute. Yeah, okay. Right. There is a cell, and every cell, except a few, have nuclei, and within these nuclei we have this genetic material or the chromosomes. So they are nothing but long strands of DNA. So if we just open these strands, we can get to the level of the nucleotide, which is the basic unit of the DNA. And we know that the DNA is made up of this helix. Yeah, so the double helix, and that's why we always say that it is a base pair. So there is pairing of the bases, the sense strand and the antisense strand. So we, all the magic, all the, the code lies here within our DNA. And we are going to study this because anything going wrong within this armamentarium will give rise to this problem. So, how do we study these genetic variants or changes in our genes or DNA? By varied methodologies. So I have just listed these tests, but you don't really need to go too much into detail, but we will probably learn as we go. So exome, I think the next slide. So let's just look at this rail track. We think that DNA might be quite like this. So it's like two strands alongside each other, connected, and it's long, millions, billions of base pair alongside each other. So lots of DNA, and then within a cell, in a working cell, this is the hodgepodge. You cannot really untangle all these DNA because they're all mixed, they're all working dynamic. But then if you straighten them out, these are the DNA, they are all separate DNAs, and within these DNA, this continuous strand of DNA, we find genes. So let's just presume that these strains are the genes. So, and we also know that these trains are consist of these coaches, which are intermittently connected to each other. So like we can say that one coach is like an exon. And within that coach lie lots of individuals or windows, which we can say base pairs. And here is the start. So we also know that within the gene, there is something called in the initiation codon, or even prior to that, we have the promoter and all that, regulator regions. So we can draw a lot of simile by this in a gene. Many a times historically, people have basically drawn a simile of a gene to like a paragraph, where they say that all the words are exons and all the letters are the nucleotides. So whatever you may understand, basically we know that this is all our genetic material and we need to study them. And there can be a defect at any region. So this is the next generation sequencing technology, which basically came around about a decade ago. And this has revolutionized the genetic testing. So prior to that, it was very difficult to sequence one nucleotide after the other. So that was called like the Sanger sequencing method. But now this is possible to multiplex. So we can actually sequence the entire DNA sequence by using this methodology, which is simultaneous or massive parallel sequencing. So this is the new age genetics. So next generation sequencing or massive parallel sequencing. So this enables multiple segments of the DNA to be sequenced at any given time. You can use these for small panels. You can limit your sequencing to like a few genes, or you can limit it to the coding regions of all the genes, which is called an exome. Or you could, take it all together, like the whole genome. So what's the difference between genome and exome? Can you just give me a second? My cat. Right. So we'll soon get to cases. So I would like you to bear with me for a few minutes. So we know that our entire human body has got 3 billion base pairs. And only 1% of this genome we have been able to unravel. And this is what we call is the coding region, that is which consists of these genes. And that is what, when we sequence, is called an exome. So we have about 20 to 22,000 genes spread all over these 23 chromosomes, and all are supposed to be in pairs. So we have taken only about 1 to 2% of the entire DNA, yet we are able to cover 85% of all the disease-causing mutations, because we are actually taking a concentrated DNA, which is the coding regions. So that's why exome is much more popular than a genome. So I hope by now you have understood the basic difference. So now let's see, what do we do? Clinical practice of genetics. What do we really on a daily basis encounter in our neonatal period? So first and foremost are these malformations. They could be isolated, they could be multiple, they could be like a pattern, they could be minor or major. So secondly, even if the baby doesn't have any malformation, it can become acutely sick, unexpectedly become sick right at birth, or maybe a few days or hours after birth. There could be acute sickness due to anything, like lethargy, seizures, like neurological insult, or sometimes you see the microcephalies, you can see overgrowth, growth restriction. Sometimes you find all these metabolic instabilities like hypoglycemia, acidosis, and you could then also note the dysmorphisms. So we'll probably go through 1 or 2 scenarios here. And then other things that points towards genetics is when a family comes with a family history of a genetic disorder, or supposedly a suspicious genetic disorder, and for whom the baby is at risk. And of course, the other now upcoming scenarios are newborn screening. So we'll just go ahead and probably start off with these cases. So this was a 24-year-old lady referred. So this is actually not a case of a neonate, but it was a pregnancy. But here there is a malformation. So this was only a gestational period when we noted that on the ultrasound there was a heart defect. And on the echocardiography, there was a large VST, pulmonary valve stenosis with overriding of aorta. So most likely this was a tetralogy of Fallot. So the family was referred for genetic testing. So we took this family, and then we took our extended family history, and we noted that the mother's brother also had a VST, and he was operated, and now he's doing quite well. So there may or may not be a family history. And had this baby been born, he would have been born with a major congenital heart defect. So what do? We go around and do the tests. So of course, like any other specialty, we go with the history and and all that investigations. And then we tested this pregnancy by amniocentesis, and we noted basically a fault in the chromosome. So this particular case was that of a deletion of the chromosome number 22q11, which we all know is the most common microdeletion syndrome. So basically, this is what we find in when we see major malformations. Majority, 20-30% of them will show up with some kind of a chromosomal error, whether it is a deletion or a duplication, whether it involves small portion of the chromosome or the entire, like we see in trisomies. So that's how these chromosomal disorders manifest. Now, risk for recurrence depends on whether the parent is a carrier. We can go ahead into the second case. Okay. So this little baby was born healthy. There is no malformation here, but the baby presented at a few days of life, day 8 of life, with lethargy and poor feeding. So like as usual, baby was managed like sepsis. There were all markers also. There was low TLC and platelet counts were low. There was dyselectrolytemia. Along with that, there was some renal involvement, liver function was deranged and all that. So, but there was not much evidence of sepsis. So then the baby was worked up for a metabolic condition, and there was acidosis noted, and baby was actually referred to Ganga hospital for that. And there were a lot of metabolic derangements noted, notably metabolic acidosis with ketosis and hyperammonemia. So the metabolic testing in this baby revealed a diagnosis. So these are the differentials for any baby who presents with acidosis and all. So these are the metabolic tests that were done in the baby that picked up the diagnosis. So basically, the MSMS showed elevation of the propionyl carnitine, which is the C3 that you may all know. And the urine GCMS showed a huge peak of MMA, the methylmalonic acid, along with other metabolites, which were quite consistent with the diagnosis of MMA. So MMA is a metabolic condition, is an eminently treatable condition by diet and medications, and sometimes there are B12 responsive cases as well. So here we utilize these biochemical genetic modalities to diagnose these children by TMS and GCMS. So in this particular case, the child went on to receive treatment at our hospital, took a lot of days, but eventually we were able to discharge the child and is doing well. Then we switch scenarios to dysmorphism. Very often we find dysmorphic babies being born and in our ICUs. Many of them are quite recognizable, like the Down syndrome, the trisomies, and many other microdeletion syndromes. However, there are also not just aneuploidies or chromosomal, there could be some kind of imprinting disorders, which we can see rarely. Like this particular neonate was large for gestational with this protruding tongue, did not have an omphalocele, but yet there was some irregularity in there was like a phantom hernia on the abdomen. So this was a Beckwith-Wiedemann baby. This is a very rare condition of Kagami-Ogata, where the baby presented with dysmorphic faces, with omphalocele, with arthrogrypose. There were some contractures, and with a coat hanger rib-shaped X-ray. So this was very characteristic, and we could pick up the diagnosis just based on these very peculiar features. So both of these disorders are imprinting disorders. Beckwith-Wiedemann syndrome is due to imprinting at a particular region on chromosome 11p15, whereas the Kagami-Ogata is due to imprinting defect on chromosome 14. So now coming to scenarios where there may be a family history and the babies who are born would be at risk. So this was an interesting anecdote that I would like to share. So this is the futility and utility of the next generation sequencing that we most of the times utilize for carrier testing. So as you would also be aware, we see a lot of couples coming to us for counseling and trying to get an answer as to why their babies, one baby or multiple babies, died without any diagnosis. So we came across two families. So this is family number one, where the couple had come to us prior to pregnancy, and then there was a pregnancy, that there were two infant losses. This baby died at 1.5 years of age with clinical symptoms of respiratory distress, coma, and lethargy. This baby died quite suddenly, so no testing was done. The second baby came along and died at 3 months of age with pretty much similar scenarios with respiratory distress, lethargy, and progressive encephalopathy. This baby had some biochemical genetic testing in the form of TMS, or also called MSMS, which had shown increased C3. So that was all that we had. And there was no DNA or no sample of the babies, only this history and one report of C3. So even the GCMS was not done. So we went ahead and did the targeted carrier screening of the couple, and we noted one variant in the MMAB gene in both the parents. So we usually do simultaneously. We did in the mother, and then we tested the father for this gene, and both of them were carrying this variant in the heterozygous form, which means that they were carriers. Now, since we came to know about this, a very likely scenario that these babies may have had MMA, and that was the reason for their sudden death. So then came along this pregnancy. We were able to test the pregnancy. In fact, because we had not tested the proband, which is the person who's affected, we noted that the pregnancy, the mutation was there in the homozygous form in this pregnancy. And we took some amniotic fluid and we sent it for GCMS abroad, and that showed the elevation of MMA. So that's like a good evidence that the baby fetus would have MMA. So we were able to diagnose this third baby, and they terminated this pregnancy. So here is the utility. So even when we didn't have the DNA of the affected babies, we were able to help this couple take a decision on their pregnancy. Now, it's very similar scenario happened in this particular simultaneously. This was again a non-consanguineous couple who had lost their baby in the neonatal period and without a diagnosis. When we probed further, they told us that yes, this baby had a respiratory distress, and it was admitted in an NNU, and TMS was also done. And there was some elevation of some metabolites, which we could not get a hold of. So looking at this suspicious scenario of a metabolic condition, we again started out to do carrier screening of the couple. Now here, we did not find any variant in any of the relevant genes in either of the couple. So the couple went ahead with the pregnancy, knowing that we could not diagnose this in the pregnancy. So the pregnancy was managed as usual. The baby was born, the baby boy was born in our hospital, was kept under observation, and we sent off a newborn screening for this baby on day 3 of life, which detected an elevated C3 or propionyl carnitine. And this was followed up very quickly by urine GCMS, which showed massive elevations of methylmalonate, 3-hydroxypropionate, methyl citrate, all consistent with diagnosis of MMA. So now this baby was proactively treated and is doing well. Genetic testing wise, we tested the baby and we actually noted that this baby was actually having a homozygous deletion of one of the exons in MMA gene. So this is one of the fallacies of the next generation sequencing or whole exome sequencing, that you are not able to detect these deletions or duplications. So that's the futility of this genetic testing. So the parents were carriers of this condition. Only one copy of their 2 copies of MMA gene was deleted, and that could not be picked up in a heterozygous state because of the presence of this one copy. The sequence was read and there was no problem. So it just went unrecognized. It only came around when the condition became homozygous. Both the copies were not present in the baby, and that's how we could test and detect it. So we are still learning, and the NGS is not there yet. So coming along, another case, this is a baby who was born to non-consanguineous couple, was uneventful, antenatal and birth, was discharged, and a newborn screening sample was taken on day 3 of life as a routine. So the newborn screening was performed at another center for 7 disorders, including an expanded IEM panel. So the results were abnormal, and that was the reason the baby was referred to us. The abnormality was that there was a raised galactose level. So what could be the differential for galactose? So each lab should build their own cutoffs and all. Usually, like in our hospital also, we keep more than 50 as high. So there are many differentials. They're not just one. There are 2 types of, the galactosemia that are possible. In fact, 3 types. One is the galactose 1-phosphate uridyl transferase, the GALT deficiency. Then there is galactokinase deficiency. And there is also a newer type 4 galactosemia, which is called galactose mutarutase deficiency. And then coming out of galactosemia, there is another differential for citrine deficiency. So this child Okay, so this is the Lilloyer pathway. I need not delve into the detail. So we first of all, we confirmed the elevation of galactose, and in the plasma, the galactose level was very high. It was 7,500 as opposed to 50. Then we did the Galt enzyme. So Galt enzyme was pretty much normal. This was well within the normal range. So we went ahead and did molecular testing for the galactokinase, and we found the homozygous pathogenic variant in this gene. So the baby now has galactokinase deficiency, which was proactively picked up in an asymptomatic condition by newborn screening. So that's the utility of newborn screening, and this baby is now under follow-up. So this is what was done immediately after that. Early cataract was identified. The mother's milk was discontinued, was changed to lactose and galactose-free milk formula. So baby is doing well. So what are my conclusions? So genetic disorders, especially inborn errors of metabolism, are not rare now that you know. So this is actually coming very quickly into the mainstream. So newborns are especially vulnerable. Because usually all the severe spectrum of the disorders are evident in the newborn period, and they are very life-threatening as well. So it is important to know them, because their significance is increasing day by day, especially when you are surrounded by the advancement in technology. All these commercial labs that are coming, they're doing all sorts of advanced tests. So there is no way that you can keep your eyes shut to that. So we must know about these disorders, try to diagnose them, and so that we are able to treat them, because that's what makes the dramatic difference, by doing the timely intervention. Stuck somewhere. Okay, so of course we know that not all the time can we save the babies. So in such situations where the baby is really sick or dying and non-salvageable, one must at least try and store the samples. Like I told you those two cases where none of the babies who died had samples available. We could have easily picked up the disorder if the sample was available. So it's really in your interest to store these samples. If you do not have facility to store the DNA, you could at least store the dried blood on the filter papers. And of course, please counsel the families accordingly. We understand in that heated scenarios, you may not be able to think of next pregnancy, but you can just tell them to come and see you back in a couple of months when things settle down. Thank you for your attention. So I will just stop sharing.
Yeah, sure, ma'am.
Stop.
Thank you so much, ma'am, for such an informative session. I think it was short, crisp, and everything got covered and without burdening much. Like genetics was always like a load for us. We don't prefer reading genetics, avoid reading genetics because we don't understand that and we don't try to understand that as well. So thank you so
I think it's best learned by case scenario. So because it is so vast, you can't just sit and read and get all the hang of it. That's why I put in these cases, so that one gets the idea. I would love to have some questions from the audience.
So the participants can either write their questions in the chat box or they can unmute themselves and they can ask the questions.
All right. In case you don't come up with any questions, you can contact me later via Gunjana or whoever, right? So
I have a couple of doubts, ma'am.
sure.
There are sometimes, for example, there are cases which, like encephalopathy especially, the patient come up with us with only, at the time of birth, there's no history of asphyxia, the MRIs are normal. and
Mm.
just an encephalopathy and nothing else in the baby. And there is nothing which could be explained. And many a times, like recently, I came across two cases where we have done a whole exome sequencing. Eventually, that turned out to be as negative. We could not
Mm.
find any pathological variants. So, how to proceed in such cases? Like as you told, that might be deletions and duplications, which might not.
So it's not all just that also, because we think that we have done everything and we rely too much on the lab for them to tell us what is wrong with the baby. The thing is that it's very vast, 20,000 genes. Practically speaking, we don't know much about at least 10 to 12,000 genes. We only know some things about the disease causation in a few thousand genes. So number one, the disorder may be falling into that category where nothing is known. So the lab will never be able to identify. Number two, lab is always dependent upon the clinical information. So as much information you can provide to the lab, the better. So by just saying that baby has encephalopathy would mean really nothing. You have to give more. You have to give all the biochemical parameters. You have to give the family history. If there is consanguinity, please mention that, because then they will it will be easy for them to narrow down to a few genes. So they can concentrate on the more relevant gene. So that's why the diagnostic yield is not much if you randomly just do the exome without any clinical phenotype. So it's really important. So the importance of the other tests, the simple LFT, the echocardiogram, the X-rays, should not be undermined. They are very, very important. And it's all together that we are able to find a result. Like you would remember this case of Kagami Ogata, we would never have had a report on whole exome sequencing. It's just by the clinical inputs that you are able to get that answer. So it's really important to have that clinical input.
We have a couple of more questions in the chat box, ma'am. We have 4 minutes left for the meeting. Either we can read
Okay.
again and then we can take up those questions.
It's up to you. I have time. So if you want, I can rejoin, not a
I
problem.
think, ma'am, we can rejoin because I've noted down the questions. We can rejoin
Okay.
and so that there will be no interruption in answering the questions.
Sure.
I request
So
everyone
let's
to rejoin so that we can take up the questions with ma'am. I have noted down the questions, so don't worry that you have to post it again.